Currently, we expect to have the acute treatment period finished for all of our patients by the end of the year. If our data review committee suggests we need some more patients, that may spill into next year. We do have a one-year follow-up because one of the things we are concerned about is to make sure all of our data says that we should have, if anything, a beneficial effect on killing the tumor size. But we want to make absolutely sure that we followed patients for a year, and by tweaking the immune system, we are not making remissions more difficult. Again, all of our data suggests that will not be a problem, and if anything, it may actually help because the host response to the tumor is important for the tumor, just like it is for the oral mucositis sort of problems. However, we will be looking at the efficacy data, which is the development of oral mucositis. If we see that we have a substantial reduction in oral mucositis, as a small company, we will then go out and try to raise money for a much larger phase 3, which will supply enough data, we would hope, to get the FDA to allow us to actually begin marketing this. Again, if everything ran completely right, which it rarely does, we would anticipate that we would begin planning the trial probably this time next year. We wouldn't actually initiate that trial until we had the final safety data from this particular trial, but we would hope to follow on very, very rapidly. The other thing we would seriously consider is that this drug has a number of other activities. For example, as I mentioned in the animal studies, there are the possibilities of using this in other types of cancers. Patients who have chemotherapy, 40% of all chemotherapeutic patients are going to get oral mucositis. Those who get chemotherapy will also have other problems with the GI system. So we would consider sort of expanding our narrow, sort of perfect patients as far as a clinical trial is concerned to a much broader group. We also, I mentioned that our drug enhances the removal of bacteria. We have some fairly exciting data that you can take a multiply resistant Staph aureus, for example, in animals, give them injection of this very common, very deadly problem that we see in hospitals all the time, and kill all the animals. If we give our drug, we can reduce that mortality by almost 50%. What makes this very unique is this is not an antibiotic. You can mix the bacteria with our drug and they're very happy. What we're doing is we are modulating the host response and making the host be much, much more aggressive in removing these bacteria. So if we've proved that our drug has biologic activity in people, completely different sort of indication, but that would give us the opportunity to begin to look at this in other types of diseases.